Hi, I'm Keith Boniface, Chief of Emergency Ultrasound at George Washington University. Thanks for joining me as I talk to you today about right heart strain and echocardiography. This first video will focus on assessing the size of the right ventricle. Subsequent videos in this series will address other B-mode and color Doppler features of right heart strain, as well as pulse wave Doppler evaluation of the right side of the heart and differentiating acute from chronic cor pulmonale. Point-of-care assessment of right ventricular size most commonly involves a comparison between the relative diameters of the RV and LV, otherwise known as the RV to LV ratio. Other size parameters have been used, including end diastolic diameter and fractional area change, but these are less commonly utilized at the point of care. The best views for the comparison of the right ventricular size to the left ventricular size are the four-chamber views, either from the apex on the apical four-chamber or subxiphoid. Another parameter that's important to assess when you're looking at the right ventricular size is the thickness of the RV free wall. This can be an important indicator of the chronicity of elevated right-sided pressures. Normally this thickness is less than 5 millimeters, while the RV that has faced volume or pressure overload for a period of time will hypertrophy to greater than 5 millimeters. And this is best measured from the subxiphoid view. The apical four-chamber view is best for comparing the size of the two ventricles, followed closely by the subxiphoid. The parasternal long axis view only visualizes a slice of the right ventricle outflow tract, so it can be easy to underestimate the true size of the right ventricle. Normally the ratio of right ventricle to left ventricular size at end diastole is 0.6 to 1, and if you're tracing end diastolic areas, the ratio should normally be also 0.6 to 1. Moderate dilatation of the right ventricle is seen when the RV to LV ratio is between 0.6 to 1 and 1 to 1. And anything where the right ventricle is bigger than the left ventricle is considered severe dilation. This is an apical four-chamber view showing a small triangular shaped right ventricle and a larger, thicker walled bullet shaped left ventricle. The apex of the heart is occupied by the left ventricle in the normal patient, and normally the ratio of end diastolic diameter from the RV to the LV measured about mid-chamber is 0.6 to 1. In this scenario, you don't really need any formal measurements. The eyeball works well. This is a patient who had a cardiac arrest and who was given TPA. These turbulent echoes in the right side of the heart are from a big bolus infusion, which is likely encroaching further into the left side of the heart. Now when you look here, the right ventricle occupies the apex of the heart, which should make you consider whether this is actually the right ventricle that you're seeing here, or whether it's possible that you have your probe flipped. So two things that can help you to determine this are looking at the level of where the tricuspid valve inserts into the septum, and normally the tricuspid valve inserts somewhat more apically than the mitral valve. The other thing that helps confirm that this is oriented correctly and this enlarged chamber is the right ventricle is that in a little bit of this view you see that this turns into the apical five-chamber view with the aortic outflow tract arising from the left ventricle here, confirming that this chamber that's larger is the right ventricle and the smaller chamber is the left ventricle, marking this as severe right ventricular dilatation. Again, on this subxiphoid view, measurements aren't necessary. This is a massively dilated right ventricle, twice as big as the small, compressed left ventricle. In this apical four-chamber view, the right ventricle is dilated and thick-walled, markedly bigger than the left ventricle. This is not the ideal view to measure the right ventricular free wall. The subxiphoid would probably be a better choice, but it most certainly looks thicker than 5 millimeters. In other words, chronic pulmonary hypertension and chronic right ventricular overload. Be careful not to measure the trabeculations that you see here at the apex and include these into your wall diameter. Measure at an area that doesn't include these deep trabeculations. The bottom line, an RV that is bigger than the LV, in other words, an RV to LV ratio of greater than 1 to 1, is severely dilated. This is a case of a patient who presented with dyspnea and hypotension, and the chest X-ray was obtained after intubation, which showed an enormous cardiac silhouette. And I think anyone listening to this video, watching this, can agree that a point of care echo would be the best next test. And so we get this view on the subxiphoid approach, showing a massively dilated right heart with spontaneous echo contrast visualized throughout the right atrium and right ventricle, consistent with a low flow state, and almost complete collapse of the left ventricle by the massively enlarged right ventricle. And this patient actually had undergone tricuspid valvulectomy for endocarditis over 20 years prior, but had never had the staged tricuspid valve replacement after he had cleared his bacteremia and he had been lost to follow-up. So in summary, when you're evaluating the size of the right ventricle, comparing the right ventricular size to the left ventricular size is important. And normally the RV to LV ratio in end diastole is 0.6 to 1. An RV to LV ratio of greater than 1 to 1 is consistent with right heart strain. And the apical four-chamber view, or if unable to get the apical four-chamber view, the subxiphoid view, are the best views to assess this relative size difference. Another parameter that's important to measure when you're evaluating for right ventricular size is the RV thickness. Normally at end diastole, the RV free wall thickness is less than 5 millimeters. Anything larger than 5 millimeters can indicate chronic hypertrophy and can give you an idea as to how long this overload has been affecting the right ventricle. And the subxiphoid view is the best view to assess for RV thickness. And you can use either B mode or you can put your M mode cursor across the right ventricular free wall.